Good evening, and welcome to tonight's Men's Health webinar with Dr. Etai Goldenberg. Tonight, Dr. Goldenberg will review the signs, symptoms, and treatment options for stress urinary incontinence and erectile dysfunction. You're invited to ask questions anytime during the presentation. To do so, please navigate to the chat feature on either your tablet, laptop, PC, or mobile device. You move your mouse or tap your screen, you'll see a toolbar. Hit the chat one, type your question in, hit submit, and Dr. Goldenberg will answer those questions halfway through the presentation and then again at the very end. Again, you're invited to ask questions anytime during the presentation. Without further delay, I'd like to introduce Dr. Goldenberg.
Hello, thank you everyone for tuning in. I hope everyone can hear me okay. My goal for today is to talk about men's health issues, focusing on two issues, on stress incontinence and erectile dysfunction. The idea of this talk is really informational, so it's supposed to be an open dialogue. Please feel free, like Mike mentioned, to put comments in the chat that will allow us to communicate and ask any questions, and hopefully we can answer them as we go through the presentation. Here. This is me. I'm Dr. Goldenberg. I'm one of the urologists at Urology of St. Louis. We are the largest private practice group in the St. Louis metro area. We have offices in Missouri and in Illinois. We actually have 11 offices. I go to 2 of them, one in St. Louis near Missouri Baptist Hospital, another one at Anderson Hospital in Illinois. I did my urology training at Washington University, and then I went to New York and did an extra year of fellowship training, focusing in men's health issues, specifically sexual dysfunction and fertility. And so my goal today is really to talk about issues that men have in terms of sexual function and stress incontinence. So I want to talk first and focus on stress urinary incontinence and what the options for treatment are. So to start off, what is incontinence and who has it and what are the causes? So to review the normal anatomy in the man or in a woman that wants to urinate, this is the bladder. The bladder is the vessel or the organ that holds urine. It's a muscle that is a muscle that sits right here and holds the urine. When a man wants to urinate, the bladder then fills. When the bladder then fills and it's time to pee, the muscle squeezes and pushes the urine through this tube called the urethra. The urine then goes through the prostate, through the sphincter mechanism, and then out the urethra. When man doesn't want to urinate, as you're holding your urine in the storage phase, there's muscle inside the prostate and muscle inside this muscle here called the sphincter that keeps the urine in place. So that way, when you jump, when you cough, when you sneeze, urine doesn't leak out. Incontinence or leakage of urine happens for 2 possible reasons. One is stress incontinence. When you cough, sneeze, lift something heavy, that muscle unit that you have that protects from leakage isn't strong enough or has been injured in some reason that the urine then leaks out. Another possible reason is that you have what's called urge incontinence. Urge incontinence is when the muscle of the bladder squeezes in a way that you don't want it to, usually too often or too strong, and at times that you don't want. It's that gotta go feeling that you can't hold, and the urine then leaks through the urethra, overcoming that muscle that's protecting. Some men have what's called mixed incontinence, so a combination of both of these. My goal today is to focus on stress incontinence. Stress incontinence, like I said, is the leakage of urine when you cough, sneeze, lift something heavy, and the urine leaks through. The most common reason a man that has stress incontinence is because they had some type of surgery on their prostate, most commonly prostate cancer surgery. So it's very common for men that had prostate surgery to have some leakage initially, but about 10% of guys that had their prostate removed for cancer do have some leakage after that initial year of recovery. And that's the most common reason where I'll see men in my office for stress incontinence. In addition, men that had their prostate removed for benign reasons, surgeries like a TURP or a laser prostate removal that are done for enlarged prostates, also do have a potential of leakage. So what happens when a man has prostate cancer and has their prostate removed is the prostate that's pictured here has cancer in it. So surgery that's usually done robotically, an incision is made here where the prostate begins the bladder, and an incision is done here at the end of the prostate, right where the urethra is, and then the prostate is removed. In order to get the prostate out, the nerves that sit here that run along the prostate are peeled off gently, normally in what's called a nerve-sparing prostatectomy, allowing those nerves to stay in place. Those are the nerves that are important for maintaining erections after surgery. Once the prostate's removed, this area is disconnected, and the urethra is then sewn back into the bladder. At this point, when you don't have the protection from the prostate, you're relying on your external sphincter that was pictured before, that sphincter mechanism to hold the urine in. So as men recover from prostate surgery, oftentimes that muscle isn't as strong as it needs to be. We strongly recommend strengthening that muscle with Kegel exercises. Sometimes that muscle is not strong enough and other things need to be done in order to protect from leakage. So what are the options a man has that had incontinence after their prostate surgery? Most commonly, when we start off, we tell men that they should reduce how much fluid they drink, especially before they go and do an activity that may cause them to have leakage. Planning restroom breaks. So if you know that you normally leak during exercise, making sure you urinate before you exercise in order to keep your bladder as empty as possible. Like I mentioned before, strengthening of that pelvic floor or strengthening of the muscle you have left behind is helpful to reduce leakage. This includes pelvic floor physical therapy, Kegel exercises, and biofeedback. And then other things that can help cope with the leakage include use of pads or diapers, condoms that go outside the penis in order to collect urine, or catheters that go inside that can drain the bladder. I usually use the pad count when someone comes in the office to really assess how much someone's leaking, asking them how many pads they run through. Pads can also be a way that can be a nuisance to patients, not only because they're wearing pads, but also because of the potential cost of many years of going through many pads. So if a man has leakage for that first year after the prostatectomy, we highly recommend working on those strengthening exercises to help increase the capacity of that muscle. If a man has significant or bothersome leakage after the surgery, there are two potential options that are surgical that can allow for long-term fixes of incontinence due to stress. Those include a male sling and an artificial urinary sphincter. I'll talk about these more in a moment, but briefly, a male sling is a piece of mesh that goes under the urethra and supports the muscles that's left behind. This is a really nice option for guys with mild to moderate incontinence, guys that still have some control of the muscle, but it just needs an extra support. An artificial urinary sphincter replicates the muscle that is normally there, and men that don't have any muscle control left, men that you have a sling that hasn't functioned anymore or that didn't work for them, or men that had their prostate removed and had radiation therapy and have severe incontinence, often would benefit from artificial urinary sphincter. So in a little more detail, the sling procedure, which is this piece of mesh, is placed, as you can see here in this picture, underneath the urethra, giving the muscle some extra support. So the way the surgery is performed is a small incision is made under the scrotum and we find the urethra. This blue line represents the external sphincter, the muscle that was left behind that does have some function. And the mesh goes here on the outside of the urethra. And then when it's pulled and tightened, it gives this extra support. And you can see this is represented by elongating that blue line, meaning that the muscle that's there has more control and more support. That piece of mesh is shown here. The way it's placed is it's looped through the bones in the obturator canal or through the hips and then tightened. That mesh then has to sit in place and scar in over the course of 6 weeks. And so after the surgery, most men have to take it easy for about 6 weeks, and they can get back to their full activities. A sling is a really nice option for guys that have mild to moderate incontinence, which I usually quantify as 4 pads or less per day, men that do have some residual control of that muscle. The success rate and satisfaction rate is very high with these patients. About 92% of patients are satisfied, or 94% would recommend this procedure to a friend. It's a minimally invasive procedure. When I do these surgeries, about half my patients go home the same day, and about half will stay in the hospital overnight. Most men will keep a catheter in their bladder overnight and then have the catheter removed the next day, and hopefully immediately have minimal to no incontinence or loss of urine after that time. The other option is artificial urinary sphincter. An artificial urinary sphincter is really a replacement to the sphincter muscle that used to be there. Like I said, I think this is the gold standard. It has been out for the longest period of time and has the longest success rate, but it is a pretty invasive procedure, because what we do is we encircle this cuff around the urethra, replacing the natural mechanism that was supposed to be there, and put a pump that is controlled in the scrotum connected to a pressure balloon here. When a man wants to urinate, you squeeze this pump. What it does is it opens the cuff and allows the urine to run through, and then it fills back up over 2 to 3 minutes. The success rate with the surgery is very high. Oh, I'll get to that in a second. And satisfaction rate is very high too. If you look here, so here is the pump that sits inside the scrotum. When a man squeezes the pump, it opens up the cuff that allows the urine to come through the urethra, lets you urinate, and then subsequently around 2 to 3 minutes later, the cuff then closes back up and it keeps you dry again until your next time to urinate. 90% of men are happy that they had this device placed. 96% would recommend it to a friend. I will say in my practice, the happiest patients I have are men that come in and need an artificial sphincter, usually men that are leaking 5-6 diapers in a day. We put a device like this in, and they tend to be my happiest patients if we can get them to a really changed quality of life. My goal with the surgery is to get a man to 1 pad or less per day. It really is a great option for guys that have, that had either failure of a sling, or that had severe incontinence that a sling was not appropriate for them. The entire device is placed inside the body. It's not detectable to others, and has a very high satisfaction rate. Both these surgical options do have potential risk. With the sling, there's a possibility that placement of the sling was not invasive enough, and you still have some leakage. We could put the sling in too tight, requiring catheterization for a period of time. There's a possibility that it's so tight you have significant difficulty urinating, or have a weakness of your urinary stream. There's a small risk of infection and a small risk of bleeding. With an artificial sphincter placement, there is a small risk of infection. That infection rate sits about 2%. There's a possibility to put the device in and it doesn't function appropriately, where it doesn't allow you to have enough control, where you still have some leakage, or that's too tight and you do have retention of urine or inability to urinate. There's a possibility when we put that cuff in that the urethra becomes too compressed, and that can cause erosion of the cuff at the area of in the urethra. As these devices are normally placed for men that had some type of surgical procedure beforehand for prostate cancer, in my experience, most men are covered to have placement of either an artificial urinary sphincter or a sling. We would verify your insurance, and Boston Scientific, the company that manufactures these devices, are very helpful in helping us get coverage and verifying coverage before we do any surgery. More information can be found at fixincontinence.com. And maybe to rewind real quick, if a man has stress incontinence, most of these men have already had a procedure on their prostate, which is the most common reason for leakage. So it's important to really start the conversation with your urologist that you already work with. But I think sometimes it takes the patient coming out and saying, I have this leakage after my prostate surgery. What are the options? And if that doctor doesn't perform these procedures, have them see someone like me who's a specialist in prosthetic urology and really can present you the options of a sling or an artificial sphincter, especially if you're a year since your surgery. So there's definitely the most common reason for stress incontinence is because of prostate cancer treatment. There are lots of options. It's important to talk to your urologist and figure out what the best option for you if this is your issue. So, Mike, are there any questions about stress incontinence I can answer first before we talk about ED?
Yeah, there's a couple of pre-submitted questions we have related to incontinence.
Okay.
So,
you want to
go
through them and then we'll go to the next part?
The first is related to enlarged prostate or BPH and incontinence.
Okay.
So there's a question wondering if in treating someone's incontinence, or I guess in reverse, if treating BPH, that could improve their level of incontinence, or if the reverse is true, if treating their incontinence could help their BPH.
So, most of the things I talked about here are for stress incontinence, which is usually because you had a BPH procedure. So BPH is a benign prostatic hyperplasia, so growth of the prostate. If the prostate protects you from leakage and that's operated on, there's a possibility. I was going to try to show this diagram here. There's a possibility that you do have some leakage after that surgery. But on the flip side, if your prostate's still in and hasn't been operated on, some men do also have incontinence for some reason, either because they also have that overactive bladder component, which is usually treated with medication, or if they have an enlarged prostate and they don't empty their bladder all the way because the prostate's so big it obstructs or blocks the urinary outflow. Sometimes you have overflow incontinence, meaning your bladder doesn't empty all the way and then some urine can leak through. Does that answer the question?
It does.
Okay.
The second pre-submitted question is related to this person is about a year out from their prostatectomy and still experiencing incontinence. Is there any chance that this person, their incontinence will resolve at this point?
Yes. So a year out after prostatectomy is usually the earliest where I would say that you're even a candidate for doing some of these more invasive therapies. And so the thought being that up until that point, many patients will have improvement or resolution of their leakage in that first year. Now, that said, there is a real possibility with Kegel exercises and definitely with pelvic floor physical therapy that incontinence will improve. There are studies that show that even men that were doing Kegel exercises at home, and if they go and work with the pelvic floor physical therapist and strengthen those muscles, will have improvement of their control. Now, no guarantee that you get better, and that's why we have the option of the sling and the artificial sphincter. But there is, even if you're a year after surgery, there is a real possibility, especially if you've been improving during that time, that you'll continue to improve.
Thank you. Now, what is the recovery timeline following the surgery for the artificial urinary sphincter?
So artificial urinary sphincter, it's a procedure where most patients stay overnight and then go home the next day. We leave a catheter in just overnight, and the next day the catheter is removed. We leave that device that's inactivated over right immediately after the surgery. So the leakage is the same right after the surgery. There are 2 incisions, normally one under the scrotum and one on the lower abdomen. Those take some time to heal. I really recommend that patients take it easy for about 2 weeks or so, which includes no heavy lifting, sports, or sexual activity for those 2 weeks. After those 2 weeks, if you feel up to it, you can get back to most activities. And then we don't activate the device or turn the device on to stop your leakage until about 6 weeks after the surgery.
Now, is it possible, common for someone to experience leakage after they've had a artificial sphincter installed?
Having artificial sphincter doesn't guarantee that you won't have leakage. Again, when I do any anti-incontinence surgery, my goal is really to have someone to have 1 pad or less per day. Having 0 leakage, especially if your leakage was bad enough that it required surgery, is a really difficult, bar to cross. That said, I do have plenty of patients that don't leak at all, but my goal really is for you to wear 1 protective pad or less. There is a possibility that you'll have more leakage than that, and depending on kind of what the underlying cause is, especially for men that need an artificial sphincter. Like I said before, I have some guys that come in 6, 8, 10 diapers in a day. We put an artificial sphincter in, and maybe that patient's leakage was so bad that they're down to 1 to 2 pads in a day, or maybe 2 to 3. But if it's such a significant improvement, they tend to be really happy. Some of it's case by case. Also, possibility that once the artificial sphincter's in, you should reevaluate the possibility of an overactive bladder, because it's possible that now that we fix stress incontinence, you will maybe have some of those irritative and overactive symptoms.
Now, following a surgery, are there any driving limitations immediately, and then any activity limitations longer term?
Yeah, so for really any surgery where you have anesthesia, you can't drive for 24 hours, and especially if you're taking narcotic pain medicine. I recommend that most of my patients, after an artificial sphincter or a sling placement, really refrain from driving for a week or so if possible. You're sore, you don't really want to drive when an incision right in that spot, and especially if you're taking narcotics, I don't want you to be compromised when you're behind the wheel.
And then longer term, are there activity restrictions, like can somebody ride a bike or?
Oh yeah, so with a sling, I tend not to give any restrictions. With an artificial sphincter, that cuff really does sit on the perineum, so right on that scrotal area. If you sit on a hard surface, you may have leakage with an artificial sphincter that works perfectly well. But if you sit on a hard surface, especially on skinnier patients where that hard surface really comes in contact with the artificial sphincter, it may push on it and cause some leakage. It won't cause harm, but it will kind of cause it that you will leak more than you'd want to. Riding a bike, sitting on a hard bench, especially, I picture like benches at a football game where my patients will like bring a pad to sit on.
Thank you. Looks like there's no further questions at this time.
Okay, so if that's the case, I will move on to talk about erectile dysfunction. So erectile dysfunction, or ED, what is it, who has it, and what are the causes? So ED, I'll admit every patient kind of has their own interpretation or thought process of what ED is for them. But in my mind, I think ED is the persistent inability to achieve or maintain an erection that's firm enough to have sexual activity. How common or how prevalent is it? I think, I always look at this slide, and I do this presentation 4 or 5 times a year, and it's always surprising to me how common erectile dysfunction is. It's 1 in 5 Americans, so about 20% of men 20 or older, and more than half of men over the age of 40. So it's a really common problem that men have. That makes it about 40 million American men. When you think about the erection process, the idea is the penis itself is made of 3 tubes. There's this blue tube, which is the urethra that we talked about before, that is where urine comes through. And above it, there's 2 cylinders, these corporal bodies. Those are what fill with blood when you get an erection. So when I think about a man getting an erection, what happens is, to start off, you have to be in the right mood and be stimulated appropriately. Some of that depends on being in the right place and the right state of mind, and also the right amount of testosterone. Testosterone is the hormone that helps with that desire and want for sexual activity. Once that signal leaves your brain to go down to the penis, you have to have normal nerve endings and normal blood vessels that go to the penis and allow for the blood to fill. These cylinders then, when are told to do so, dilate and fill with blood. So the blood there's an artery or a blood vessel that brings blood into each of these corporal bodies, and there's small veins that then collapse to keep the blood inside during sexual activity. What are the most common reasons why this won't work for a man the way it used to or the way it should? Most commonly, these are vascular problems. So 40% of men that have erectile dysfunctions because of a blood flow issue. Like I explained before, it's really important in order to get a normal erection, to have blood vessels that function appropriately, and therefore anything that causes blood vessel issues are the most common reasons. High blood pressure, high cholesterol, and diabetes often will affect blood blood vessels. In addition, certain medications that affect blood flow, most commonly blood pressure medicines, can affect erections. In addition, pelvic surgery or prostate surgery are really common reasons for erectile dysfunction. So erectile dysfunction and diabetes is very common. Erectile dysfunction occurs much earlier in men with diabetes than it does in the general population. In addition, men that have diabetes tend to get less of a response to erectile dysfunction pills than the general population. So it's really common for men to come in with more severe erectile dysfunction and much earlier when they come to the office at a younger age. Things that can affect your ability to get an erection with diabetes are often your age, so the number of years that you've had diabetes, how well your diabetes has been controlled, also the presence of other type of microvascular complications, or nerve issues. Guys with neuropathy of their fingers or their toes are more common to have erectile dysfunction as well. Erectile dysfunction and heart disease. So as I mentioned before, to get an erection really is a blood flow issue. You need to have the right amount of blood flowing into the penis. If you look at this diagram here, the penile artery present here is about 1 to 2 millimeters in size. You compare that to the blood vessels that are in the heart that would get blocked up when you have a heart attack, that are about 3 to 4 millimeters in size, or the artery in your neck, the carotid artery, that's about 5 to 7 millimeters in size. Any man that has a history of a stroke or a history of a heart attack most likely had a narrowing of these larger blood vessels. So in my mind, if you have enough of an underlying problem that these blood vessels got narrowed, almost for sure there's some narrowing in the penile artery. There's some literature to say that a man that with erectile dysfunction has a higher chance of having a heart attack, and vice versa. Men that have had a heart attack have a higher chance of having erectile dysfunction. Ways to reduce your risk for erectile dysfunction because of heart disease include exercise, dieting, low stress, and not smoking. Like I talked about before with low testosterone, testosterone is the hormone that's made from the testicles and gets into the bloodstream and helps with sex drive, desire, and energy. Many men develop low testosterone as they age. About four out of every 10 men over the age of 45 does have low testosterone. It's really common to have low testosterone associated to other risk factors also for erectile dysfunction, which include being overweight, having diabetes, or having a high cholesterol or high blood pressure. If you have a low testosterone, often men will complain of feeling tired or run down. They'll complain of being sluggish or having poor memory, and often will have low sexual desire and erectile dysfunction. The way you test for a low testosterone is a blood test, actually 2 blood tests. You have to have 2 blood tests that show that your testosterone is less than the cutoff of 300 nanograms per deciliter to be diagnosed with low testosterone. If your testosterone is low, most commonly we'll give a trial of medicine to get testosterone. So one option is to give you medicine to kind of trick your brain to send stronger signals to your testicles to make testosterone. But most commonly what we do is we give a man with low testosterone replacement therapy. That's done with either a gel or an injection or a pellet that goes under the skin, and actually newly FDA approved pills to get that testosterone. And what you get is you get the increase of that testosterone, that hormone in your bloodstream, and hopefully help with sexual desire. And in many men will help give them better erections or give them a better response to some of the treatments for erectile dysfunction. In terms of prostate cancer, this picture is the same I used before to talk about how the prostate's removed. When you have prostate cancer and have a prostatectomy, the prostate is removed by making an incision here above and below the prostate. In order to get the prostate out, these nerves that run along the prostates are freed up. To free up those nerves in a nerve-sparing prostatectomy, at minimum, will kind of traumatize those nerves by pulling them off the prostate, and sometimes will permanently injure those nerves. In many men, their erectile function improves over the first year or sometimes 2 years after their prostatectomy. But it's very common for there to be persistent erectile dysfunction after a prostatectomy or after the prostate's removed. Overall, about 50% of men that have their prostate removed will have erectile dysfunction. In addition, the other option for prostate cancer is radiation therapy. And again, approximately 50% or half of men that had radiation therapy will also develop erectile dysfunction. And men that had their prostate removed and had radiation therapy have an even higher chance of erectile dysfunction. I want to touch for a minute about Peyronie's disease. Peyronie's disease is plaque or scar that forms inside the penis and on the outer side of this corporal body. So when a mild injury occurs, some men overdevelop a plaque or scar. What happens is when that scar is there, the erection becomes less elastic. So the penis just doesn't stretch as much as it did before. And so when you get an erection, the area where that plaque is does not stretch the way it did before and causes curvature in the area where that plaque is located. There are lots of options to treat Peyronie's disease. Simplest things, there are stretching exercises or use of a vacuum erection device or a penile traction device in order to stretch the penis. There's one medicine that's FDA approved for treatment of Peyronie's disease, that's Xiaflex. Xiaflex is injected into the plaque over the course of 8 injections over 4 cycles in order to break that plaque down. In addition, surgical interventions can be performed to help with curvature. That's either a plication procedure, which is a shortening of the penis on the opposite side of the plaque, almost forming an artificial plaque on the opposite side, allowing for straightening, incision or excision or removal of that plaque, and then putting a graft in, or doing a penile implant, which is a procedure I'll talk about more in a moment for men with a severe erectile dysfunction and Peyronie's disease. So treatment options for erectile dysfunction. So there's really been a lot of potential therapies out there. More and more family practitioners and primary care doctors have become more comfortable to prescribe some of the therapies for ED. These are things like Viagra and Cialis and things like that tend to be prescribed lots by primary care doctors, and I think feel more comfortable prescribing those medicines. However, if those things aren't working, or if you would like to see a professional, I think it makes sense to go to a urologist to talk really focusedly on erectile dysfunction and really have that be the reason for your visit. In addition, someone who's a prosthetic urologist, someone like me that focuses in treatment for ED, may allow you to really hear about all the options that are available. And so in my mind, the options that are available for someone who comes in with erectile dysfunction are oral therapies or pills, wave therapies, injection therapies, suppositories, vacuum devices, and penile implants. And I'm going to talk more about each of these. So oral therapies have been on the market now for about 30 to 40 years. These are pills that allow the blood vessels in the penis to dilate and stretch more. The idea is the PDE5 inhibitors cause a reaction in the penis and that more nitric oxides in there, and therefore you can maintain your erection and get a firmer erection. Viagra is a medicine that we give really commonly. You want to take it about an hour before sexual activity. Cialis, which works a little differently, actually lasts in the system for longer, up to 36 hours. They're effective in about 60 to 80% of patients. And like I mentioned before, sometimes don't work as well for men that had prostate surgery or men with diabetes. Many men complain that these therapies are very expensive at their pharmacies, so we started doing it in our office, is offering them at a cost pay here at our office to allow men to try these therapies. Side effects of oral therapy. And these include headaches or stuffy nose. Really commonly, some men will get low back pain with these medications. Some men can't take these type of medicines because they take other therapies like nitroglycerin. Nitroglycerin reacts with PDE5 inhibitors and cause an unsafe drop in your blood pressure. So if you have heart disease or if you're written for nitrates, you need to talk to your cardiologist before you can try these medicines. Low intensity shockwave therapy is something that's being advertised a lot more. We've started doing this at our office about a year ago. The way it works is that a device is used to apply these acoustic waves to the penis to allow irritation to the blood vessels in the penis. And the thought is that when these waves go through the blood vessels in the penis, they cause neovascularization and repair to some of the damaged blood vessels. The thought is that it can help repair blood vessels that are in there to allow them to function better and feel better with sexual activity. The way the therapies work, you come to the office on 6 occasions, about each session is about 30 minutes, and have the therapy performed. And the hope is that it will improve erectile function. In my experience, it's really great for guys with mild to moderate erectile dysfunction because it really only gives something like a 25 to 30% improvement of erectile function. So men with severe erectile dysfunction or erectile dysfunction that's not because of blood flow, because of nerve endings, tend not to do as well with this therapy. Shockwave therapy is off-label. It's not an FDA-approved treatment, but in my mind, the risk is very low, and it could be a beneficial option for men, like I said, with mild to moderate erectile dysfunction. A vacuum erection device is a cylinder that goes over the penis. It pulls blood inside, and then you put a ring on the base of the penis in order to maintain the erection. This can be powered either mechanically with a battery or with a manual pump. The idea is once the blood's inside, you leave the ring on the penis to maintain the erection during sexual activity. The satisfaction rate sits somewhere between 60 and 80%. The downsides is that there are complaints about the ring causing blockage of the ejaculation or discomfort in the penis, and which that's the most common reason why men will stop using the vacuum device. A urethral suppository is probably one of the least common options that we use for erectile dysfunction. This is placement of a small suppository or dissolvable pellet into the urethra. It gets absorbed over the course of 5 to 15 minutes and then gets absorbed by the erectile bodies. And when it's absorbed by the erectile bodies, those bodies dilate and blood flows in. The side effects are it can cause lightheadedness and dizziness. So I have men evaluated and kind of watched in the office, usually the first time we do this, to make sure that their blood pressure doesn't drop too much. Some discomfort or blood in the urine can happen. More commonly, when men have failure of pills or wave therapies, I tend to recommend a trial of injection therapies. When we try these injection therapies, I do a test dose in the office to assess how it works for a man. The way it works is a tiny needle is injected into the side of the penis, delivering a medicine that brings in a vasoactive substance, so something that causes the blood vessels then to dilate in the penis. About 60% of guys have a really nice response to this. The average guy takes about 5 to 10 minutes to get the erection, and the goal is that erection to last about 45 minutes or so. There is a risk of bruising or discomfort from the injection. It is very potent, and so there's a small risk of having a prolonged erection that won't go away, which is called a priapism, and that's why we test you the first time in the office to make sure it works really nicely. And the other option for men that have tried all these options and have failed them or have been dissatisfied with the potential of using those therapies, or they say, I don't like needles or those haven't worked for me, is a penile implant. A penile implant is a surgical procedure where we replace the inner parts of the penis. We replace those cavernosal cylinders with cylinders that are filled with saline or salt water. They're controlled by a pump that sits in the scrotum and a reservoir that sits in the abdomen. It's a very highly efficient procedure. It's a device that's completely concealed inside the body and tends to work really nicely. It's a surgical procedure, so there is potential risk, and those risks include infection or bleeding or injury to surrounding structures. Because we put the device inside, that's a mechanical device, it can break down. The average device does last about 10 to 15 years and then may need to be exchanged. There are different types of these implants, including a spectra or a malleable device. These are cylinders that replace the cavernosal bodies and that are bendable, so they bend down and then you bend them up when you're ready for sexual activity. A two-piece device, which are cylinders that go in the penis controlled by a pump, that really goes from being about 70% firm to being fully erect, and a three-piece device, which is the most common. This is yellow because it's coated in antibiotics. It has the pump that sits in the scrotum, the two cylinders, and the reservoir that sits here in the pelvic area. The AMS 700 device is coated in antibiotics to reduce that risk of infection. Previously, there was a higher infection rate with these devices. And then with the introduction of this antibiotic coating on the device, I tell my patients if they're getting a penile implant, their risk of infection is about 1%. So how does this work? So what a man does when they want to get an erection once the penile implant is in place is they squeeze this pump. The pump then shifts the fluid from the reservoir into the cylinders. The cylinders then fill. Then you can then keep and maintain your erection for as long as you'd like. And then you can push this release button, and that release button opens this valve back up, allowing the fluid to escape from those cylinders and go into the reservoir. Here's a live patient, which I think sometimes helps really give a better visual of what these implants look like. So as you can see, the device really is completely concealed inside the body. You can then bring the pump up to the skin surface and squeeze it this way. I think most of my patients actually squeeze with their fingertips more than their full hand, but it's really whatever's most comfortable for you. Once the device is inflated by squeezing on the pump, you can see that the cylinders fill inside the penis and allow for a rigid and erection. And then you can keep that erection for as long as you want. And then when you're done, you can pull that pump back up to the skin surface that you can see there. The release button is right there. You press that release button, and then it opens the valve, allowing the fluid then escape. If you'd like, what you can do is then squeeze the penis afterwards and get all the fluid out of the cylinders in order to have a very flaccid penis until the next use. Like I mentioned before, very highly successful procedure. Well into the 90% of patients and their partners are satisfied with these devices. There is real risk associated with a penile implant surgery, and that, like I mentioned, that 1 to 2% risk of infection, possibility of pain after the procedure. It is a surgical procedure, so there's a risk of going to sleep, having anesthesia, and the small risk of bleeding. In addition, the device may not work for you the way you want it to, or it may have a mechanical problem that needs to be revised. Like I said, the average device lasts around 10 to 15 years. It's designed to be a permanent solution for erectile dysfunction. It's spontaneous, and you keep the erection as long as you'd like. Insurance coverage is often out there for placement of a penile implant. Before we put a penile implant inside, we will always verify your insurance coverage and let you know of any copays that would be necessary. Boston Scientific, who is the manufacturer of the device, does a really good job really verifying and helping us to make sure we know and that you know what your out-of-pocket expense would be. Overall, taking a step back, erectile dysfunction is very common, can be associated with many other medical conditions. There's lots of treatments for erectile dysfunction. There's lots of guys on this call today, and there's not one answer that's right for them. I think it's really figuring out what the right option is for you and for your partner to figure out what options to try. And some of it is trial and error, going through the different options and seeing what fits for you. And some of it is coming to a talk like this and hearing kind of what's out there and knowing really what's available. So, I really kind of empower you to start by talking to your primary care doctor, talking to your urologist, or if you're interested, seeing me or someone like me that's interested in prosthetic urology to talk about all the options that are available. I'm really lucky to have Cliff here to talk about his experience. So Mike, maybe what I'll do is jump over to Cliff and then answer questions at the end. Does that work?
That sounds great.
Perfect.
Get Cliff off video.
Good evening. I hope everybody can hear me.
Yep. Got you.
Great. Basically, what you're going to hear is the journey that I took with my wife from the time I was diagnosed with prostate cancer through the time I was having ED and then having conquered it. Basically, 19 years ago, when I was 57, I was diagnosed with prostate cancer. And after all these meetings with the doctors, I decided the best thing to do was to have the prostate removed. I had the prostate removed, and needless to say, I had a little insufficiency, continence insufficiency, which did go away, but I did develop ED. So I went back to my regular doc, my internist, and he said, well, we put you on Viagra. That was fine. Unfortunately, I was one of those people that the Viagra just gave me such bad headaches that I just had to lay down and I could not pick my head up off a pillow. So they switched me to Levitra and then to Cialis. And in all 7 months, none of them did me any good because of my reaction to them. So I went back to my internist and he said, well, the only other thing I know of is this external vacuum device, this pump. And I said, okay. And we bought one, and I'll just let you know, it's one you want to buy with a prescription from your doctor from a medical device store. It's not one you want to buy for $25 from one of these sex places. Those are garbage. You really need a good one. Does work, works very well. Unfortunately, there are a few problems with it, and that is, it is not spontaneous whatsoever. Number two, what happens is when you have your erection, your penis becomes a little cold. It turns a bluish color, and it doesn't look very natural, which is kind of a turnoff to your partner. The other thing that I found the most discouraging about it was taking off that band. Coming up shaft of the penis was not a problem, but basically, once I was up off the shaft, coming over the head really hurt. And after about a dozen times using it, did away with that, and then went into a major depression because I had no other idea what else was available for ED. Luckily, back then, I got an invitation to a meeting like this, and I learned about the little pellet muse. I learned about the injections, and I learned about the artificial implant. I wasn't happy about injections myself. The muse didn't really turn me on, but my wife and I talked about the fact that the implant, even though there was a slight risk of infection, was something that would be with me all the time. It's totally spontaneous. I don't have to worry about going on a vacation and keeping medication cold or anything like that. And so the day after my 60th birthday, I had the implant done. I will tell you, it is the best, or I would say the second best thing I ever did in my life. The first one was marrying my wife. The implant, just like the doctor said, I was home from work for 2 weeks. I went back to work after 2 weeks. I then went back to the doctor. He showed me how to use it. I used it for a week and a half, 2 weeks. And once it was totally usable and healed, and I had figured out how everything worked, it was the beginning of the 6th week. We started having relations again. And I was amazed, and so was my wife, at the amount of intimacy we had lost while I was suffering from ED. So it brought back a lot of intimacy. I will say a lot of things, a lot of people ask me bunches of questions like, what happens when you go through the airport and you go through the devices to determine whether you have any metal on you? The device does not turn anything on at all. So it's very, very quiet It doesn't do anything whatsoever. The second thing is people ask me, well, what about, can you still have MRIs and scans and stuff like that of your abdominal area and your scrotal area? And the answer is yes, you can. It doesn't affect that. It has no effect on your urinary tract whatsoever. I will tell you, I had my implant, my first implant, like I said, I was 60. It lasted till I was 74. It was 14 years. At 14 years, it stopped working. And I went back to the doctor and had a revision done. This September, past September will have been 2 years. And I will say it works terrifically, just as good as the first one. I have absolutely no complaints whatsoever. If it lasts another 14 years and I last 14 years, I'll go back and get another one. It's as simple as that. But it really will change your life. And the fact is, you don't have to worry about anything. You can keep that erection up for as long as you like. You don't have to go to the hospital with priapism after 4 hours. And all I can say is it will bring back your manhood. And I know what it's like to lose it because I lost it for 3 years. And it really, really brings you back to being a full functioning man. And I will say one other thing. If you have a partner, I would suggest very highly that you involve your partner when you go to speak to the urologist and the prosthetic urologist so they understand exactly what's going on. I get a lot of comments from men saying that their partners have said, oh, he must be having an affair with somebody. He doesn't love me anymore. I don't turn him on anymore. And that's the furthest from the truth. And the reality is once they learn about what's really causing it and how to fix it, it becomes a couples issue. And it really is important that both of you know. So I'll turn it back to you, Mike. And any questions for the doc or me, that's fine.
Thank you very much, Cliff.